Graham Smith, Menopausal Symptoms as Predictors of Long-Term Adherence in the International Breast Cancer Intervention Study, IBIS-1.
Okay, thank you very much for attending today. I have no conflicts of interest to declare. So to date, there have been 9 randomized trials testing the effectiveness of selective estrogen receptor modulators in a primary prevention setting. A meta-analysis of individual-level participant data showed that women taking SERMs have a reduced risk of breast cancer of around 30%. Data from the IBIS-1 trial, one of these primary prevention trials, shows that this effect lasts for at least 20 years. Women taking SERMs also experience a risk of an increased risk of thromboembolic events, endometrial cancer, and menopausal side effects. We aim to assess the role of menopausal symptoms on adherence in the IBIS-1 trial. We included UK women from the trial who are aged 35 to 70 at increased risk of breast cancer. We excluded women who had died, who experienced an invasive cancer diagnosis during the treatment phase, and also who experienced a serious thromboembolic event, or DVT, or who underwent prophylactic mastectomy. We assessed menopausal symptoms, any menopausal symptoms that the woman experienced prior to trial entry, as well as menopausal symptoms at 6 months, as none mild, moderate, or severe. These menopausal symptoms were nausea and vomiting, which we combined due to their low prevalence and similarities, irregular bleeding, vaginal dryness, and vaginal discharge, which we again combined and will be referred to as gynecologic symptoms from here on, headaches, and hot flashes. Adherence in this trial was defined as 4.5 years on therapy. As you can see from the baseline characteristics, they were similar across the trial arms. On average, women were 49 years of age. The majority had 2 or more relatives who had been affected by breast cancer, and their 10-year risk score was 5.7% across both trial arms. Overall, 2/3 of women, 66.8%, were adherent to therapy for the 4.5 years. There were significant differences between the trial arms, such that 71.5% of women in the placebo arm were adherent to the therapy, compared with 62.1% in the tamoxifen arm, and this difference was significant. With regard to their mean time on therapy, on average, women spent 4.1 years taking their therapy, and again, there were significant differences between the trial arm. Moving on to the symptoms that women experience, a minority of women reported after 6 months experiencing nausea and vomiting. Only 5% of women reported this symptom. 7% reported headaches, 31.5% reported hot flashes, and 20.9% reported gynecologic symptoms. Of those who did report these symptoms, the majority of them were mild. This figure here shows the percentage of adherence on the y-axis, and across the bottom we have each of the 4 symptoms. In the dark red bars you have women who represent women who reported that particular symptom, and the white bars represent women who did not report that symptom. As you can see, there's an association between women who reported nausea and vomiting and adherence, headaches and adherence, but there was no relationship between hot flashes or gynecologic symptoms with adherence. These figures are adjusted for a range of characteristics that were recorded at baseline. This figure here presents the data on the relationship between symptoms and adherence, but this time stratified by trial arm. Anything to the left of the vertical line in the middle indicates lower levels of adherence. As you can see from the nausea and vomiting, women who reported this particular symptom were less likely to be adherent in both the placebo and the tamoxifen arm. Women who reported headaches were less likely to be adherent in the placebo arm, but not the tamoxifen arm. There was no association between hot flash and adherence in either trial arm. Women who reported gynecologic symptoms in the tamoxifen arm were less likely to be adherent, but not the placebo arm. Tests of heterogeneity revealed that these effects of symptoms on adherence were comparable between the trial arms. So in conclusion, interventions are needed to manage menopausal symptoms, and dropout rates were fastest within the first 12 months of therapy, indicating that this is an optimal time in which to deliver such interventions. Addressing medication concerns prior to initiating therapy may encourage more realistic expectations of the likelihood of experienced symptoms among women and prevent them from misattributing symptoms that were naturally occurring to their particular therapy. Cognitive behavioral therapy is shown to be effective in the adjuvant setting in terms of managing menopausal symptoms, and it would be interesting to test this hypothesis in the primary prevention setting. I'd like to finish by acknowledging our funder, Cancer Research UK, and the IBIS-1 participants, recruitment sites, and trial steering committee. Thank you.
Let me ask the first question. At least in the US, it may be somewhat different in the UK. At the time this trial was initiated, many women were taking hormone replacement therapy that was then stopped at the time of their breast cancer diagnosis. Those people have a lot of hot flashes, whether they're on tamoxifen or not, and I wondered if there was any relationship or if you had enough patients to look at those who were on hormone replacement therapy and then had to stop it, and their relationship to hot flashes either on placebo or on tamoxifen.
I don't know about the relationship between whether they reported hot flashes, but we did control for HRT within our analysis and showed that there was a relationship between HRT and likelihood of adherence.
Yes.
MarisaWeiss, were patients allowed to switch from one anti-estrogen therapy to another in case one was more tolerable?
This was just tamoxifen for this particular trial. So is that what you're referring to?
Yeah. So it was either tamoxifen or nothing.
Yeah.
Okay. And have you identified what solutions might be effective in that first 6-month period that might help improve adherence?
There have been very few interventions, if any, in the primary prevention setting. In the adjuvant setting, there have been 9 trials to date that have tested interventions, and I believe one of those was successful at increasing adherence very slightly. So there's a dearth of interventions in terms of supporting menopausal symptoms, which then have knock-on effects for adherence. In terms of managing menopausal symptoms, there are a range of different interventions that could be done, and as I said, cognitive behavioural therapy is one intervention that's been shown to be effective in a UK trial, in the Menopausal trial. So that could be a possibility for the primary prevention setting.
And just how much are these side effects anticipated through the conversation, the informed consent process? How would the informed consent process be improved to help people understand what to expect and what could be done to help manage? So at that moment of engagement, I know that the trial consent form is probably this big, but what can we do up front just to help set the stage of what people expect and how that might be beneficial?
Yeah, so women who are being consented for trials, as well as this is now routinely offered within both the US and the UK, so communicating the likelihood of experiencing those symptoms is important. So what would be particularly interesting would be to look at all of the symptoms that were reported within trial arms compared with placebo arms for these trials, to look at what were naturally occurring symptoms and what were actually triggered by those particular therapies. And that way we can communicate more accurate information to patients so they can make an informed decision about whether or not they want to participate.
I might add, there are things that we can do to ameliorate the symptoms for sure. In patients on tamoxifen and who have vaginal problems, that's easy to fix with vaginal estrogen. It's absorbed, but tamoxifen works in premenopausal women who have very, very high estrogen levels. So that problem can be dealt with easily. Hot flashes are also can be dealt with in many patients with acupuncture or with a drug called Effexor and some other antidepressants that are effective in relieving hot flashes. So I think we do have things that can help those side effects.
Right. It would just seem that since those are such predictable side effects and they are a reason for non-adherence, that the opportunity at the informed consent process to say just what you're saying, Dr. Osborne, that these are commonly expected side effects and that there are many things we can do to help with them,
right. Today that
may be helpful.
Today that would be the case. Remember, this trial is very old,
Right,
20-year-old trial, and we didn't know about Effexor back then.
Yeah.
And we didn't know about acupuncture, which relieves hot flashes in 60% of patients.
Absolutely. Thank you.
Okay, thank you. We're ready for our next presentation.